So let's talk about managing anticoagulation and thrombosis remotely. We're going to use a case-based approach. Our third case is going to be around anticoagulant-related bleeding. So our 60-year-old male patient on long-term warfarin for a mechanical aortic valve, where you want to keep the INR in the range 2.5 to 3.5, a little higher, calls your office because of nosebleeds that he's been having for the last 3 weeks. He's worried about going to the ER in this time of COVID-19. He's not taking aspirin or non-steroidal anti-inflammatories. He describes bleeding intermittently, sometimes from the right, sometimes from the left nostril. It occurs about 3 times a week and lasts 20 to 60 minutes, usually resolving fairly promptly with local pressure. He's had no other visible bleeding or bruising. He's had some lab tests done, interestingly, and his hemoglobin came back at 115, showing a hypochromic microcytic pattern, normal being 125 to 140, and his INR a little high at 7. So what do we recommend here for warfarin dosing and INR monitoring, and what about vitamin K? Sorry, Lana, can I turn this one over to you?
Yes, thank you, Alan. So this is a gentleman where, as Dr. Duquetis mentioned, warfarin is our only anticoagulant option due to the aortic valve that he has. It's a mechanical valve, so we cannot use a direct oral anticoagulant. And although his INR is slightly elevated outside the range at 3.7, what's also interesting and concerning is that he has a hemoglobin of 115, suggesting that perhaps there might be some other bleeding happening beyond just the nosebleeds that he's describing more recently. And in the setting of nosebleeds that are happening as frequently as they are, lasting anywhere from half an hour to an hour, I do think this is a patient where, if it's at all possible, to bring them into your office so that you can examine them and potentially do cautery to the nostrils to identify a vessel that's exposed and bleeding. I do think that's an important consideration that we can do to minimize ongoing bleeding. Other things to consider, especially in the drier winter months, is whether or not they're using a saline spray, for example, to keep the mucosa moist. Using a nasal lubricant would offer the same sort of strategy. So if it's at all possible to try these conservative measures to minimize ongoing bleeding, and then bringing your patient in for an assessment and potential cauterization, if you have the ability to do that, that would limit further nosebleeds potentially. In terms of what do you do with the warfarin dosing, so on the right-hand side of the screen, you can see a clinical guide that we have, which gives recommendations for modifying the warfarin dose depending on where the patient is with their most recent INR. And it will give you this recommendation in terms of proportion of dosing increase or decrease of the warfarin, and when to do the next INR test. And so I think that's a nice tool that you can refer to on the website. In this setting, I wouldn't advocate for giving vitamin K because our patient isn't having significant hemoglobin drop with the nosebleeds. And although it is a frequent occurrence of the bleeding, I don't think we need to entirely reverse the anticoagulant effect, because we need to balance the fact that we don't want his valve to thrombose and potentially cause a stroke. And so vitamin K is really reserved for patients that are having moderate to severe bleeding, or for patients where their INR is significantly elevated without bleeding, and that's typically when the INR is measuring above 10, for example. Next slide, please. So what are the things that we can do to reduce a patient's risk when they are on an anticoagulant? And so, as Alan mentioned already, our patient is not on any co-administered therapies such as antiplatelet agents or anti-inflammatory medications, which can also increase bruising and bleeding risk. So if your patients are on those medications, you want to review whether or not they're necessary. And if they can be stopped even for a short period of time, that may help to reduce the immediate risk of bruising and bleeding. And as Dr. Duquetis mentioned in the last vignette, when can you switch from warfarin to a DOAC? We have that tool on the Thrombosis Canada website. And I do want to reiterate that this patient with a mechanical valve is not the patient that we are going to switch from warfarin to a direct oral anticoagulant. That would only be in patients where they are on warfarin for atrial fibrillation or for venous thromboembolism. When can you use a low-dose direct oral anticoagulant? So the low doses are listed there. And again, the tool on the Thrombosis Canada website that helps you determine the dosing strategy is a great opportunity to review this. And if you're using low-dose direct oral anticoagulants for atrial fibrillation, it is important to do this according to the product monograph, so that we don't unnecessarily increase somebody's stroke risk, for example. So it is certainly reasonable if somebody is having bleeding complications to temporarily reduce their dose of anticoagulant, but to remember that we need to reevaluate that and increase their dose back to the correct dosing once the bleeding has resolved, so that we don't increase their stroke risk by having them on too low a dose of anticoagulant. Next slide, please. These are the types of bleeding events that we're talking about that really should not be overly concerning. So nosebleeds are certainly concerning to patients, but from a healthcare practitioner perspective, not overly concerning for us. And the measures that I mentioned earlier are certainly strategies that we can try. Bruising is very frequent and very common, especially as patients get older. And again, encourage them just to be mindful of bumping themselves and minimize co-administration of antiplatelets and anti-inflammatories as you can. And so these are examples that I think you don't necessarily need to be too concerned about.
Thanks very much, Lana. On behalf of Thrombosis Canada, I'd like to thank everyone for attending today's program. I'd like to express thanks also to Dr. Duquetis and Dr. Castellucci for their excellent presentations and answers to your questions. I also would like to thank our sponsor, Bear Canada, for their unrestricted grant for this program. And be sure to visit our website regularly and often, as we add new materials all the time and are always updating our clinical guides and tools. So with that, I wish you all a safe afternoon and safety throughout the rest of COVID. Bye-bye now.